Let me introduce the last speaker of the session, Dr. Kritika Armugam. She is a second year postgraduate OBGYN, Chettinad Hospital and Research Institute. She will be talking on factor 7A.
Very good evening to one and all present here, to all the respected legendary professors here, all my seniors and everybody present here. I put forward my heartfelt thanks to entire team of COGS and my beloved HOD ma'am, Professor Dr. Vijayalakshmi ma'am, for giving me this wonderful opportunity. And here I am here to talk about the recommendation.
The topic is on factor 7A. Our faculty, Dr. Vijaya's bag, our delicate bag is having her charger and power bank. If somebody has mistakenly taken it, kindly return.
So these are my objectives. Introduction to recombinant factor 7A, coagulation cascade, mechanism of action, indications and contraindications, the dosage, price and availability, obstetric and non-obstetric uses, complications and take-home message. Introduction. The factor 7A, also known as proconvertin, is a vitamin K dependent clotting factor which is synthesized by the liver. It plays a major role in the initiation of tissue induced coagulation in the extrinsic pathway. This initiates a cascade of proteolytic events which lead to thrombin generation, fibrin deposition and platelet activation. So what happens immediately following a trauma or vessel injury? The first step is hemostasis. First is vasoconstriction, followed by primary hemostasis by temporary platelet plug formation, and finally fibrin clot conversion. Let me give a small explanation about this coagulation pathway. For the formation of a stable fibrin clot, two pathways are involved. The first being the intrinsic and the next is the extrinsic pathway. So following a tissue injury to the vessel wall, the collagen and the tissue factor gets exposed and a series of coagulation cascade happens after that. A proteolytic events happen after that. Factor 12, 11, 9 and 8 are in intrinsic pathway and 7 and 3 are in the extrinsic pathway. These together will activate factor 10 in the common pathway, which leads to the thrombin generation, and this thrombin will further convert the fibrinogen into fibrin, thereby forming a stable fibrin clot. Recombinant activated factor 7, initially it was developed for the treatment of hemophilic patients with inhibitors, and later it was successfully used for treating hemorrhages with acquired hemophilia. This has been used with a benefit as a universal hemostatic agent in many other non-hemophilic bleeding situations. Mechanism of action. This works locally by acting on the exposed tissue factor on the subendothelial cells, and this complex will further activate factors 9 and 10, leading to small generation of thrombin. This will further activate factor 5 and 8, thus leading to thrombin burst, which will activate the fibrinogen, convert into fibrin, thereby leading to fibrin clot. The action of recombinant factor 7A is limited to the site of tissue injury and tissue factor exposure, and it is particularly useful in obstetric setting where this is often bleeding from the large raw area of exposed tissue. It is dependent on the presence of adequate number of circulating platelets and adequate fibrinogen concentration. Improvement in the lab markers of DIC by administration of blood components prior to the administration of the recombinant factor 7A are associated with better response to our factor 7A treatment. So, use of factor 7A in obstetric hemorrhage. It is a new weapon in the obstetrician's armamentarium. So, as we all know, the obstetric hemorrhage remains a significant cause of maternal morbidity and mortality, and worldwide the life-threatening hemorrhage occurs in about 10% of all live births. Main problem in obstetric hemorrhage is it can progress rapidly, and it is strongly associated with development of disseminated intravascular coagulation, and delayed correction of DIC is associated with significant increase in morbidity and mortality. Hence, a multidisciplinary approach in conjunction with a hematologist, obstetrician and intensivist is needed. So, the desirable laboratory indices before administering the recombinant 7A are prothrombin time less than 1.5 times the upper limit, fibrinogen more than 1 gram per liter, platelets more than 50,000, hematocrit more than 24% and pH more than 7.1. The use of recombinant factor 7A should be considered in obs hemorrhage in situations where the bleeding continues to happen despite optimum blood product transfusion and obstetric measures, or if uterine artery ligation or embolization or hysterectomy is under consideration, or any unavoidable delay in provision of blood products, and an Jehovah's Witness where the women will refuse blood product transfusion. So the dosage is 90 micrograms per kilogram, and the use of recombinant factor 7 should be authorized by a consultant hematologist or obstetric anesthetist prior to the administration. A single standard dose should always be kept in a delivery suite to facilitate rapid administration in appropriate circumstances. It is very important to note that it should not be seen as an alternative to surgical hemostasis or correction of coagulopathy with blood products. Further doses should be given in exceptional circumstances where examination seems likely. The other non-obstetric uses are in hemophilia A, B and C, congenital factor 7 deficiency otherwise known as Alexander's disease, Glanzmann thrombasthenia, other quantitative and qualitative platelet disorders, factor 11 and von Willebrand's disease, emergency bleeds like intracerebral or upper GI bleeds or trauma, oral anticoagulant induced hemorrhagic surgeries like liver resection or orthotopic liver transplantation, neuro or cardiac surgeries. So this is the drug. It's available in the name of Novo 7 RT, which is manufactured by the Novo Nordisk India Private Limited Company. Available in a powdered form, it is reconstituted with a diluent, and it should be given within the first 3 hours of reconstitution, and it can be given as a bolus intravenous dose. And the main disadvantage is that it costs around 39,000 per vial. For 1 gram vial is around 39,000, which is a major disadvantage. So it's available in 4 different doses, 1 milligram, 2, 5 and 8. Adverse drug reactions are rashes, urticaria, fever, most common being the injection site discomfort or hematoma, headache, dizziness and increase in the body temperature. And following the administration, after 24 hours after the bleeding stops, we have to start the patient on low molecular weight heparin, calf compression stockings, and lower limb Doppler should be done for screening of deep vein thrombosis. Complications are deep vein thrombosis and pulmonary thromboembolism, and it should be used with caution in sepsis, disseminated malignancy or any other coagulation bypassing agents due to its thrombotic potential. So these are my references, and this particular reference from Freeman Hospital in Newcastle provides evidence to support the ongoing use of recombinant factor 7A in the management of life-threatening obstetric hemorrhage as a successful adjunct to optimal medical and obs intervention. So take home message, the use of recombinant factor 7A for PPH is off-label usage, and any decision rests exclusively with prescribing clinician. And once all the surgical and non-surgical definitive hemostasis procedures to arrest have been attempted and the bleeding still continues, then definitely recombinant factor 7A should be considered. Ensure that temperature, acidemia, serum calcium, platelets, fibrinogen have been optimized before administration, and the single dose, that is 90 microgram per kilogram of recombinant factor 7A should be administered as a single bolus intravenous injection over 3 to 5 minutes. If after 20 minutes, if there is no response to the single dose, then a second dose can also be given. And in centers where no resources exist to conduct the arterial ligation or radiological embolization, factor 7 may be considered prior to the surgical interventions. And if still bleeding persists after giving the 2 doses of recombinant factor 7A, then consider hysterectomy. Thank you.
Dr. Kritika, it was well explained. It should not be the first line of treatment in any hemorrhage, and should not be used in DIC, should not be used in EPLA and protein C.
Yes.
It's quite a thrombosis forming triad, so that has to be taken care of. Thank you.
Thank you.